Okay, we have actually mentioned we finished the first sector of the four patterns of diffuse lung disease, and we started the evaluation of the ground glass pattern, and we finished by the acute presentation. If the ground glass pattern presented by chronic presentation, long-standing history with the patient, then these are the possibilities. Hypersensitivity pneumonitis, organizing pneumonia, previously known as POOP, and bronchoalveolar carcinoma, alveolar proteinosis, and you remember the ground glass pattern was present in usual interstitial pneumonia and also in non-specific interstitial pneumonia. And we start by the hypersensitivity pneumonitis, which is one of the chronic diseases that produce ground glass pattern. This is a reaction in the lung in response to inhalation of a variety of organic dust antigens. The presentation may be acute. In most of the cases, according to the literature, we see it in the chronic and the subacute in the acute phase. Then, the opacities in the lung are in the form of ground glass opacities. And in the literature, they refer it as the head cheese sign. And you know, in Europe, they got the head of the pig, the guinea pig, what do you call it, the pork, yeah, and they form like this into cubes, and whenever you cut the cube, you got three different colors. And I hope that you can find the relation between this appearance and the appearance in the lung. Can you see here that we have two different areas in the lung? You got areas that are black and the areas that are gray, and some areas are like more whiter. The, I actually I do not find the relation, but I put the two in front of you, and you know that the radiologists always have a great imagination, and they can correlate this with this. But if you see, and this patient with hypoxia and the lung opacities, then these opacities are responding to steroids, and the diagnosis was to be an asthmatic patient. And if you look here, and you got ground glass opacities, and these ground glass opacities may, if I have an enlarged picture, and you can see these opacities are intermingled with in areas of more translucency. This is the clear lung, and this is the ground glass appearance. If this appearance is chronic presentation, and then you put the hypersensitivity pneumonitis in the top of the differential diagnosis, then one may ask why I do not consider this as usual interstitial pneumonia, because of absence of traction of bronchiectasis and absence of honeycombing. Why I don't consider this non-specific interstitial pneumonia? Because there is no traction bronchiectasis. Okay, you know what I mean? Then some of the clinicians in Egypt consider that most of the cases diagnosed as non-specific interstitial pneumonia are actually hypersensitivity pneumonitis. There is a great overlap between both, and you should investigate the patient very thoroughly in order to reach the specific allergen that has caused the disease. Okay? Then you got these appearances with ground glass opacities, maybe some nodules, areas of air trapping in between the opacities. And sometimes you see small lymph nodes in the mediastinum, pulmonary arterial hypertension because of the chronicity of the disease. Then look at this patient, and then many of you may say that this is reticular opacities. Others, they will say these are brachiopacities. Then the final diagnosis is reached through the CT scan. And here you can see too many opacities in the lung. But you can see also traction bronchiectasis. Then you are in the way between non-specific interstitial pneumonia and hypersensitivity pneumonitis, which is a chronic pathology. And as I have mentioned in a moment, that most of the clinicians in Egypt consider this, that too many of the patients we diagnose non-specific interstitial pneumonia are actually hypersensitivity pneumonitis. In the chronic phase, you got fibrosis, you got traction bronchiectasis, and you got the full-blown picture of interstitial fibrosis. Then we came to this also an important diagnosis, which is cryptogenic organizing pneumonia. This type of pneumonia is also similar to xenophilic pneumonia of unknown etiology, and it has no relation to smoking, and is characterized by ground glass opacities or consolidations distributed throughout the lung, and it responds to corticosteroids. Then this appearance, which is known as atoll sign, is correlated with the opacities in the lung. What are these opacities in the lung? And you got, here is the opacity in the lung, which is similar to this island. And you got ground glass veiling surrounded by an opacity. And this is known as the reverse of halo sign, because the halo sign actually you got the opacity surrounded by ground glass, but in cryptogenic organizing pneumonia you got the ground glass surrounded by the opacity. If you see this, which is usually seen in about 20% of cases, you can swear that this is cryptogenic organizing pneumonia. Okay, and if you have the chance to see this classic appearance of opacities, the ground glass surrounded by an area of consolidation, which is known as the reverse of halo sign, and this is cryptogenic organizing pneumonia. But one of the clues also to suspect this pathology is that this lesion does not respond to antibiotics. Then if you give corticosteroids, there is adequate clearance of the lesion. If you see opacities in the lung similar to pneumonia, and they are not responding to corticosteroids, and they are not responding to antibiotics, and you give corticosteroids and they responded marvelously, then you know that this is one of two: acute eosinophilic pneumonia or cryptogenic organizing pneumonia. And this is an 80 years old patient with dyspnea and chest opacities, and these are the opacities. Actually, you cannot see the reverse of halo sign here, but this patient was subjected to transbronchial lung biopsy, and they confirmed the diagnosis of organizing pneumonia. Then we came to the we may say the second pattern, which is the consolidative pattern, where you can see area of consolidation, and you know the area of consolidation by the presence of this classic air bronchogram. Air bronchogram means that you got bronchi patent filled with air running through an opacity of abnormal, let's say fluid or something in the alveoli. You replace the air in the alveoli by other material, but the bronchi are still patent. Then you got this classic appearance, which is known as air bronchogram. Air bronchogram can be seen in the plain film and can be seen in the CT scan. Whenever you see air bronchogram, you know that you are dealing with a pulmonary parenchymal lesion. and this lesion exactly in the alveoli, and its name is consolidation. Consolidation do not mean pneumonia, but pneumonia is one of the causes of consolidation in the lung. And airspace filling means that you remove the air in the alveoli and put another material. If this material is fluid, you got pulmonary edema. If it is exudate, you got pneumonia. If it is blood, then you get hemorrhagic pulmonary disorders. If it is tumor cells, you got alveolar cell carcinoma. If it is proteins, you got alveolar proteinosis. The first three issues are diagnosed through the clinical picture of the patient. The last one has a specific imaging criteria. And alveolar carcinoma is one of the most difficult lesions that can be diagnosed radiologically, as I will mention. Then we start by edema. You remember interstitial edema, cardiogenic or non-cardiogenic. And this is alveolar edema of acute heart failure. And you got too many opacities in the lung, and you can hear on the patient's chest too many bubbling sounds through the lung, meaning that you are getting too many fluids in the alveoli. This is intimately related to the bat's wing configuration, where the heart represents the body of the bat, and the wings represents the edema. These wings may be similar, of similar size or distribution, and maybe asimilar. The one is small and one is big. But these opacities are usually more central nor than peripheral. Pneumonia is the only one that can has peripheral distribution. But most of the alveolar opacities, other than pneumonia, has a more or less central distribution. Then you got enlargement of the heart and bilateral, almost symmetrical pulmonary opacities. Many times you do not need the CT scan because the clinical picture is quite evident and you hear the bubbles on the chest of the patient. Then if you see here, they usually classify this as third stage left heart failure. The first stage is pulmonary venous hypertension, where you got dilatation of the upper lobe vessels and the reduction of the blood flow towards the lung. Then the second stage, and you got interstitial opacities, B Curlis line, A Curlis line, and so on. The third stage is alveolar opacities and bat's wing configuration. Then pneumonia has a specific clinical diagnosis. The patient is feverish, he has expectoration, he has mucus filled with pus, and you got opacities in the lung with classic air bronchogram, and most commonly they have peripheral distribution. And this is a pneumonic consolidation in the left lung and the subsegmental consolidation in the right lung. Pulmonary hemorrhage produce opacities in the lung similar to pneumonia and also similar to pulmonary edema. But the clinical picture is evident. The patient may have hemoptysis, the patient may have an underlying pathology like glomerulonephritis, like Wagner granulomatosis, one of the diseases that can cause vasculitis and lead to pulmonary hemorrhage. But actually, in the chest X-ray, it's difficult to differentiate between hemorrhage and edema unless you have positive clinical data. Then the edema has clinical data that are quite evident. Hemorrhage is also have a clinical data that are evident, but please note that some of the patients who have pulmonary hemorrhage do not have hemoptysis. This is very important. Okay. Then, if you look here, this patient has systemic lupus, and this is one of the types that can cause vasculitis and the bleeding. Then you see opacities in the lung. One of the important things here is the opacities are not peripherally distributed. They are central, more central towards the hilum. Then, in the presence of this positive history, you diagnose this as pulmonary hemorrhage. And this is another case, dyspnea, hemoptysis, and low serum hemoglobin level, and you got opacities that are classically more central than peripheral. This is very important for him. Also, Wagner granulomatosis is one of the small vessel vasculitis that can cause pulmonary hemorrhage. Then, if you know that the patient had Wagner granulomatosis and you got these opacities in the lung, one may say the patient with Wagner granulomatosis cannot have pneumonia, or he can. He can, of course. The patient with Wagner may be affected by pneumonia or pulmonary hemorrhage. Then how can you discriminate between both? Yes, yes, of course. And then you are clinicians. You should think of the clinical every time. Then the clinical of pneumonia is quite different from the clinical picture of hemorrhage. Then we came to this difficult disease, which is the bronchoalveolar carcinoma. And bronchoalveolar carcinoma means that you replace the air in the alveoli by tumor cells. And at the beginning of the disease, you got miliary opacities scattered throughout the lung. We will mention later on the differential diagnosis of miliary opacities in the lung. But after some time, these miliary opacities will coalesce to form areas of consolidation. Then one of the best diagnostic clues for bronchoalveolar carcinoma disappears. If you see a mass in the lung or a nodule in the lung, you know the mass is more than 3 centimeters, the nodule is less than 3 centimeters. And through the mass, you got air bronchogram. Then the differential is one of three, either round pneumonia or lymphoma or alveolar carcinoma. Round pneumonia is common in the pediatric age group. Then you are left with lymphoma and pneumonia and alveolar cell carcinoma if the patient is adult. And in order to differentiate these two, you should have biopsy from this lesion to know. But if you are allowed to choose one of these, you choose bronchoalveolar carcinoma. It is relatively more common than a pulmonary lymphoma. And this is one of the signs mentioned in the literature. It's known as CT angiogram sign. And you can see the enhanced pulmonary vessels on the background of consolidated lung. And this is non-specific sign for bronchoalveolar carcinoma. Another issue is the presence of an opacity that is not responding to antibiotics, not responding to corticosteroids, and it looks similar to pneumonia. At that time, you should go to have a biopsy of this lesion to exclude the possibility of alveolar cell carcinoma. Then this is also one of the good signs to diagnose alveolar cell carcinoma, which is the presence of an area of consolidation containing air bronchogram together with pulmonary nodules, either in the same lung or in the opposite lung, because these nodules will coalesce to form patches. And the only disease which produces this appearance is the bronchoalveolar carcinoma. And this is the differential diagnosis. Lung cancer has a strong association with smoking. Bronchoalveolar is not, and there is symptoms, and there is a high frequency of lymphadenopathy and metastatic disease, which is not seen here. Pulmonary infection, and you got fever, you got leukocytosis, you got cough, and the opacity is just a consolidation with air bronchogram, and it responds quickly to antibiotics. Lymphoma is one of the underlying causes that can produce similar appearance. And metastatic disease, usually you may know that the patient had a primary malignancy. And if you look here and you can see area of massive consolidation on the left side and some areas of consolidation on the right side, if the clinical picture permits the diagnosis of pneumonia, you can diagnose this as pneumonia. But if these lesions are not responding to antibiotics nor steroids, the sputum and right and left main bronchus lavage were positive for malignant cells. And this is one of the alternatives for the diagnosis, or you can have a true cut biopsy from any of these lesions. Then compare between pneumonia and alveolar cell carcinoma. Pneumonia is a peripherally distributed lesion. Alveolar cell carcinoma is not a peripherally distributed lesion in most of the cases. Pneumonia should not have nodules in the opposite lung or in the same lung. But alveolar cell carcinoma, this is one of the important findings, is to see nodules in the same lung or nodules in the opposite lung. Then you got the diagnosis of alveolar bronchoalveolar carcinoma. Then what about alveolar proteinosis? And this disease is strongly associated with smoking. There is intra-alveolar accumulation of surfactant-derived lipoproteinaceous material. And the disease has a specific imaging appearance, and it can be diagnosed also by sputum examination and bronchoalveolar lavage, and sometimes we may got lung biopsy to confirm the diagnosis. Then the classic appearance of of alveolar proteinosis is what is known as the crazy paving appearance. Then the crazy paving appearance, if you look to the plain X-ray of the chest, you cannot discriminate this from any other of the previously mentioned opacities like pulmonary edema, pulmonary hemorrhage, and so on. But if you have the CT scan and you see that this classic appearance, which is known as the crazy paving opacities, these opacities are hexagonal opacities representing the pulmonary lobule with the central ground glass area, and typically you should see parts of uninvolved lung. You see areas of involved lung and you see areas of non-involved lung, and this is known as the crazy paving. If you look to the chest X-ray, you cannot see, of course, the crazy paving, but you see too many opacities. You may call this interstitial or alveolar, but if you have the CT scan and you see the classic appearance of honeycombing, it's not honeycombing actually, but it's known as the crazy paving hexagonal opacities with central ground glass areas, and this is diagnostic of alveolar proteinosis. You can confirm the diagnosis by bronchoalveolar lavage, sputum examination, and sometimes by lung biopsy through cut needle biopsy. And this is another example of alveolar proteinosis. And we came to the nodular pattern or the miliary pattern. And the miliary pattern, we have three distributions. The first one is lymphatic. Lymphatic distribution along the border of the central lobule, along the pleural surface, along the fissure. The easiest one is along the fissure, to see nodules along the fissure. This is lymphatic distribution, and the lymphatic distributions means one of three. You remember the three? No? Sarcoid, lymphangitis carcinomatosa, and interstitial pulmonary edema. Then centrilobular distribution means that you got nodules within the center of the lobule. Then random distribution, like this distribution anywhere, nodules in the lung, anywhere. then this is the differential diagnosis. Look at here. Then look at the fissure. If you see nodules on the fissure, this is diagnostic of lymphatic distribution. What are the diagnoses? Sarcoid, and you got also pneumoconiosis, lymphangitis carcinomatosa, and pulmonary interstitial edema. If you got centrilobular distribution, meaning that nodules within the center of the lobe, and this is hypersensitivity pneumonitis, bronchoalveolar carcinoma, and in infection. Random distribution. If you got random distribution and the nodules are less than 3 millimeter, and this number 1 is biliary TB, and number 2 is metastasis. But if the nodules are more than 3 millimeter, it is only metastasis. And random distribution means metastatic disease if the nodules are more than 3 millimeter. If less, consider TB, which is the most common disease that can produce biliary shadows. Okay, then can you see the fissure, and then can enlarge this? Then this is the fissure. If you see nodules distributed along the fissure on one side or on both sides, if you see nodules along the pleural surface, and you swear this is, yes, lymphatic distribution. On top of the lymphatic distribution is sarcoid. On top, the first possibility is sarcoid. Then you got lymphangitis carcinomatosa if the patient had a known primary malignancy, and you can diagnose pneumoconiosis if you have other features of pneumoconiosis I will mention now. Then we came to the sarcoid. Sarcoid has many different classifications according to the grades. Some of the classification include grade 0, 1, 2, and so on. And other classifications include the stage 1, stage 2, A, B, C, and D, then stage 3. Then don't bother yourself. If you see lymph nodes only in the chest, bilateral, symmetrical, they are called potato lymph nodes, then you consider this is stage 1 sarcoid. If you see nodules and opacities, the opacities are one of three: reticular, nodular, or both. Reticular opacities, linear and nodular opacities, linear and nodular opacities together with lymph nodes or without lymph nodes. These are considered a stage 2. Then stage 3, and you got starting fibrosis in the lung until you end by a picture which is almost similar to interstitial pulmonary fibrosis. This is stage 3. Let us look to the stages. Forget about the stage 0 and so on. Then we came here. To start with, how to diagnose lymph nodes in the chest X-ray. You look to the frontal chest X-ray, and you can see masses, or you can see enlargement of the hilum. Enlargement of the hilum may be due to vessels or due to lymph nodes. Then you go to the lateral view. If you see a mass that is superimposed on the hilum, and this lymphadenopathy. If you do not see any mass in the lateral view, and what you have seen in the frontal view is just vessels. Okay? Then this is stage 1 sarcoid, and you see the classic appearance of what is known as potato lymph nodes in two well-defined, festooned, lobulated appearance of the lymph nodes, which may be, in many cases, they are almost symmetric, and they may contain calcium. Then, if you see nodes like this and here, together with opacities in the lung, and you can, then this is stage 2, where you can see lymph nodes in the hilum and you see nodules together with some strandy opacities. Then here you can see the classic appearance of sarcoid lymph nodes in the CT. They are discrete, they are homogeneous, and may contain calcium. The lymph nodes of sarcoid are discrete and they are homogeneous, do not contain areas of breakdown, and they may contain calcium. This is typical for sarcoid, and you can easily discriminate between lymphoma nodes, which are bulky, amalgamated, and do not contain calcium. If you got opacities in the lung, in the lymphatic distribution, you can swear that this is sarcoid. Another appearance of sarcoid, and you see enlargement of the lymph nodes and the interstitial opacities of lymphatic distribution, then you call this is sarcoidosis. Then at the end stage of sarcoid, you got opacities similar to irreversible pulmonary fibrosis, traction bronchiectasis, honeycombing, and areas of air traps and emphysematous bully. This is an end stage, what is known as end stage lung. And pneumoconiosis means that you are dealing with opacities in the lung secondary to working in industrial projects, for example, and you got the miliary shadows in the lung, which are very dense because of the composition of the nodules. And you can compare with the density of miliary TB nodules with the density of pneumoconiosis nodules. Nodules of pneumoconiosis are very dense, and nodules of the miliary TB are usually soft. Then, one of the manifestations of pneumoconiosis is the development of progressive massive fibrosis, which means that there are in the imaging two big opacities in the upper part of the chest on either side of the mediastinum. This is classic appearance of progressive massive fibrosis and is considered by some in the exam as a spot diagnosis. If you see two big masses here, especially if they contain calcium, two big masses in the upper part of the chest on either side of the mediastinum with some randomly distributed nodules throughout the lung, you may consider progressive massive fibrosis, and these are the appearance of the nodules on the CT scan or the masses, and also you can see calcium more better than in the plain X-ray. In this coronal CT scanning, you can see two big masses on either side of the mediastinum with parenchymal calcification. Then the centrilobular nodules, we have mentioned something about hypersensitivity pneumonitis, and I said that you may see some nodules. I mentioned also bronchoalveolar carcinoma and the pulmonary infection. Then we came to one of the specific centrilobular nodules, which is known as tree-on-bud appearance. What do we mean by the tree-on-bud appearance? And this is what do we mean? The early appearance of the buds in the tree. This corresponds to the appearance in the chest, and this is known as the tree-on-bud appearance, which is almost specific for TB. And if you look here, the TB is one of the common lesions that produce tree-on-bud. Also, lymphoma is one of the pathologies that can produce this appearance. Then a typical infection also may cause this, but whenever we see this, we recommend highly to examine the sputum for TB. Also, the tree-on-bud may see in cases of bronchiectasis. These are dilated bronchi, and I will explain the issue of bronchiectasis later on. Then you can see some opacities that looks like tree-on-bud. Infection bronchiolitis is one of the diseases that can also produce this specific centrilobular nodules, which is known as the tree of bud appears. Random nodules. If the nodules are less than 3 millimeter, considered TB. If they are more than 3 millimeter, considered metastasis. Then biliary TB is one of the manifestations of tuberculosis that can be seen in the primary or secondary TB. And it is of relatively poor prognosis according to the literature, and the infection reaches the lungs through the blood. Then you can see extensive pulmonary nodular opacities of softer density than pneumoconiosis. And if you look to the chest X-ray, and one may say that this is consolidation, another one say nodule, another one may say mixture, and you go to the CT scan. High resolution CT is the only way to separate opacities from each other. And you can see miliary shadows, then you are dealing with miliary tuberculosis. Here you can see soft, widely scattered nodules, and by CT you can see too many miliary shadows representing miliary TB. Of course, if you see miliary shadows in an HIV positive, you know that this is miliary TB. Then miliary metastases are nodules that are more, let us say, less than 3 millimeter and also more than 3 millimeter, randomly distributed through the lung. And you should know that there is a primary malignancy, which is in most of the cases in the thyroid, because you know that thyroid is one of the most common locations to produce biliary metastasis, and also the pancreatic cancer, the breast, and so on. Then this is papillary thyroid carcinoma. You got miliary shadows in the lung, they are metastases, and this is the CT scan showing extensive miliary metastasis in the lung. Finally, we came to the cystic pattern. Cystic pattern means that you have too many air-containing cysts in the lung. And the differential diagnosis is one of 6. Histiocytosis or Langerhans cell histiocytosis, emphysema, cystic bronchiectasis, tuberous sclerosis, lymphangiomyomatosis, and lymphocytic interstitial pneumonia. Then we start by a well-known rule that you cannot diagnose cystic pattern from the plain X-ray. You cannot diagnose cystic pattern from the plain X-ray. All what you see is the wall of the cysts. Then diagnose this as reticular pattern. And if you go to the CT scan, you can see that it is actually a cystic pattern of diffuse lung disease. The possibilities. Number one is histiocytosis, and many of the clinicians cannot accept the diagnosis of histiocytosis unless the patient is a smoker. If the patient is not a smoker, they say, no, this is not histiocytosis. Then this disease has an intimate relation to smoking, and it usually affects the upper and the middle lung zones and usually spare the bases of the lung, in contrast to lymphangiomyomatosis, as I will mention. Then you see infiltration of the lung parenchyma by histiocytes will result in the formation of nodules. Then the nodules will coalesce to form bigger nodules, and the bigger nodules will cavitate, resulting in cystic spaces filled by air distributed throughout the lung. Then any of these cystic changes may rupture and produce pneumothorax. The criteria of the cysts are randomly distributed. They spare some areas in the lung. They have thick wall. They are usually more than 10 millimeter in size. these criteria are important. Number one, they spare part of the lung. They have thick wall and they are usually larger than or in the range of 1 centimeter in diameter. This appearance is classic for for histiocytosis. If you see these cystic changes with relatively thick wall and some areas of the lung are spared, then you think of histiocytosis. Remember that histiocytosis usually do not affect the lung bases. It is usually concentrated in the apex and also in the middle lung zone. Some of the nodules may rupture to produce pneumothorax. Pneumothorax may induce surgical emphysema, as you can see here. Then, as the disease progress will lead to destruction of the lung. And this will lead to bizarre shaped areas of cystic changes, pulmonary hypertension, and air trapping. Pleural effusion and nodes are relatively rare. And this is one of the complications of histiocytosis is rupture and the development of pneumothorax. The main line of treatment is to stop smoking. Then you give corticosteroids and so on. The second one is lymphangioliomyomatosis, which is almost confined to females in the childbearing period. And this disease is a multi-system disorder. And you know, it's intimately related to the tuberous sclerosis, I will mention just in a moment. The underlying pathology is proliferation of the smooth muscles that can obstruct the venules, lymphatics, and the small airways, resulting in areas of air trapping. You cannot diagnose cystic pattern from the plain X-ray. All what you see is the wall of the cysts. But if you go to the CT scan, then you see these cysts do not spare any part of the lung. Number one, this patient should be a female patient. Number two, the cysts are very numerous. They do not leave any part of the lung. The cysts are smaller than histiocytosis, and they have relatively thin wall compared to histiocytosis. These are the differentiating points. Also, these cysts can extend into the costophrenic angle. They do not spare the lung bases. Then you see here, the cysts are distributed all over the lung. They do not spare any part of the lung, and they are relatively smaller, and they are of relatively thin wall. Here you see the cystic areas distributed throughout the lung. The patient should be a female patient. The same complications, rupture of one of the cysts resulting in pneumothorax. Then lymphangioliomyomatosis may be associated with abdominal finding, and this is very common in the tuberous sclerosis, where you can see bilateral renal angiomyolipoma, big masses in the kidney containing fat, splenic cysts, chylous ascites, and chylous effusion, of course, lymphangioliomyomas everywhere, uterine fibroids, which is part of leiomyomas, and abdominal lymphadenopathy. Then the differential diagnosis of lymphangioliomyomatosis is mainly histiocytosis. But you know that histiocytosis can occur in children and the others, male and the female. You know the intimate history to cigarette smoking. You know the upper lobe and middle zone distribution. No affection of the lung bases or the costophrenic angles. The cysts are large and thick wall of irregular contour, and they do not, the lymphangioliomyomatosis do not spare any part of the lung. I will mention lymphocytic interstitial pneumonia immediately now. Then the third one, we have finished this, the first one, histiocytosis. The second one, lymphangiomyomatosis. The third one is emphysema. And emphysema is a well-known diagnosis from the plain film. You got flattening of the diaphragm, widening of the retrosternal space, widening of the retrocardiac space, and prominence of the central hilar shadows, and also decrease in the peripheral lung markings. You see the distance between the ascending aorta and the back of the sternum is big, and also the distance between the chest wall and the back of the heart is big. Then we have two types or three types of emphysema: the centrilobular and the paraseptal and the mixed type. Centrilobular emphysema means that the emphysematous bulli are distributed in the central part of the lung. Paraseptal means that the emphysematous bulli are located in the subpleural location. And this is the classic distribution for emphysema, the paraseptal one. Then, if you see paraseptal emphysema and some emphysematous lesions in the central part of the lung, you know that this is mixed type of paraseptal and the centrilobular. This is centrilobular emphysema, and you got too many emphysematous nodules, and you can see that emphysematous bulli have no perceptible wall. Emphysematous bulli have no perceptible wall compared to histiocytosis and lymphangiomyomatosis. You cannot appreciate the wall of the bulla, and the bulli are, of course, of variable sizes and different appearances. And you see here too many emphysematous bulli located on the periphery of the lung in the subpleural and also in the central part of the lung. The tuberous sclerosis, I have mentioned before that you got the changes similar to lymphangiomyomatosis in the chest, as well as the abdominal findings, mainly the two big masses in the kidney containing fat, which represents angiomyolipoma. And this is the case of tuberous sclerosis. You got ground glass opacities, you got cystic changes in the lung, and it's important to see these lesions in the abdomen to confirm the diagnosis of tuberous sclerosis. And you see two big masses in the kidney containing fat, maybe unilateral mass, only a single mass, or bilateral masses. Another example, the manifestations of tuberous sclerosis in the brain is subependymal periventricular calcification. And here you see two big masses in the kidneys containing fat, and you see cysts in the lung. This is the full-blown picture of tuberous sclerosis. Also here, cysts in the lung and two big masses in the kidney representing tuberous sclerosis. Cystic bronchiectasis is one of the lesions that can be diagnosed from the plain film, provided you see the cystic lesions with thick wall along the distribution of the bronchi, and very commonly you see fluid levels inside the dilated bronchi, denoting the presence of secondary infection. But you can confirm the diagnosis of bronchiectasis, of course, by the high resolution CT. And you have too many appearances: the tram track sign, the signet ring sign, and the string of pearls sign. All these signs are mentioned in the books to diagnose bronchiectasis. They do not mean a significant issue, but you can easily see that these are tubular bronchiectasis. And this is another appearance of tubular bronchiectatic changes in the lung. And this is what we call the signet ring sign. You see the vessel represents the stone, and the bronchus represents the ring. And you can see the difference between the size of the bronchus and the size of the adjacent vessel. Many times, cystic bronchiectasis contain air fluid level due to the presence of secondary infection. This is the distribution of bronchiectasis if they are located in the upper lobe, and this is cystic fibrosis and TB, which are responsible for upper lobe distribution. the central part of the lung, cystic fibrosis, allergic bronchopulmonary aspergillosis, and congenital tracheobronchomegaly. Lower lobe bronchiectasis is commonly seen in pediatric infection, in aspiration, and in immunodeficient patients. This is cystic bronchiectatic changes containing multiple air fluid level. And you can go to the coronal reconstructed images and you see multiple cystic dilated bronchi. Finally, you got the lymphocytic interstitial pneumonia. Lymphocytic interstitial pneumonia is one of the pneumonias that can appear similar to the previously mentioned one, especially the presence of nematocytes. It is intimately related to HIV pneumonia. But this lesion, you should know that the patient had an autoimmune disease, specifically the Sjögren's disease, in order to diagnose lymphocytic pneumonia. Look at the CT images. This patient is an HIV positive man with long-standing asthma. If you look here, and you can see many cystic areas containing air, and you can see also some faint ground glass appearance. Then this patient is immune compromised and is known to have HIV positive. Why you do not consider this as Jirovecii, pneumocystis jirovecii? It has the same appearance. It has the ground glass appearance. It has nematocytes, and many times you got the overlap in the diagnosis between lymphocytic interstitial pneumonia and pneumocystis jirovecii, especially if the patient is HIV positive. Then you have thickening of the bronchovascular bundles, which is not an issue, but you got ground glass opacities, you got cysts, like these cysts filled with air, and you may find sometimes mediastinal lymphadenopathy. We cannot discriminate if the patient is HIV positive, but if he is, then you consider jirovecii, pneumocystis jirovecii, more common than lymphocytic interstitial pneumonia. But if you know that the patient had Sjögren's, especially Sjögren's in particular, then you know that what are you looking for is lymphocytic interstitial pneumonia. And this is another example, lymphocytic interstitial pneumonia. This is the differential diagnosis mainly in pneumocystis craniae pneumonia, and can be difficult to differentiate, particularly if you know that the patient is HIV positive. But it's easy to differentiate from histiocytosis because of the smoking, because of the appearance of the cyst, and also it's easy to differentiate from lymphangiomyomatosis because of the sex of the patient and the distribution of the shadow. Conclusion. We have 4 patterns of diffuse lung disease, and we start first by the reticular pattern. What is the reticular pattern? And you see interstitial opacities, ground glass opacities, bronchiectasis, and honeycomb. And if you see all these, the first primary diagnosis is usual interstitial pneumonia. If there is no evident clinical cause, you call this idiopathic pulmonary fibrosis. Then the honeycombing is not evident, then the diagnosis is non-specific interstitial pneumonia. If you know that the patient has congestive heart failure, the diagnosis is interstitial edema. If you know that the patient has collagen disease like scleroderma, rheumatoid, and so on, then you call this collagen related. If you know the patient is receiving some kind of drugs, then you call this drug induced. The remaining in the differential, you know, interstitial opacities, ground glass, bronchiectasis, honeycombing, usual interstitial pneumonia, no cause, idiopathic pulmonary fibrosis. If there is a known malignancy, then the diagnosis is lymphangitis carcinomatosis. If the patient is known to have sarcoid, Then this is sarcoid related in the stage lung. Then we came to the ground glass. The ground glass pattern, if it is acute presentation in a cardiac patient, the diagnosis is pulmonary alveolar edema. In a non-cardiac patient, the diagnosis is ARDS, acute respiratory distress syndrome. If there is eosinophilia in the blood picture or in the lavage, acute eosinophilic pneumonia. And you remember that this type of pneumonia do not respond to antibiotics, and it responds to corticosteroids. If the patient is HIV positive, pneumocystis jirovecii. If the patient had fever, cough, and sputum, viral pneumonia. Okay, then the chronic pattern of ground glass. If the patient has exposed to allergens, hypersensitivity pneumonitis. Reverse of halo sign, cryptogenic organizing pneumonia. And this also the type of pneumonia which does not respond to antibiotics. If you have the crazy waving, pulmonary alveolar proteinosis, and this disease is intimately related to smoking. Alveolar pattern, constitutional symptoms, fever, cough, pneumonia. Okay. Then chronic congestive heart failure, alveolar edema. Crazy waving, alveolar proteinosis, which is intimately related to smoking. Hemoptysis is pulmonary hemorrhage. And there should be a known history of vasculitis like systemic lupus, Wagner granulomatosis. Bronchoalveolar carcinoma. Bronchoalveolar carcinoma. Nodules and patches, mass with air bronchogram and CT angiogram sign. You remember, patches and nodules is very specific, more or less, and mass with air bronchogram and CT angiogram sign. Then multiple patchy opacities simulating pneumonia with no response to antibiotics. Acute eosinophilic pneumonia. How can you diagnose? Yes, peripheral eosinophilia and the reverse of halo sign. Then the CBC showed peripheral eosinophilia, lavage showed peripheral eosinophilia, and the response to antibiotics. Cryptogenic organizing pneumonia. Yeah. What? The reverse of halo sign. Okay. Bronchoalveolar carcinoma. And we have mentioned nodules and patches, mass with air bronchogram and CT angiogram sign. All these lesions do not respond to antibiotics. And lymphoma is also one of the lesions that do not respond to antibiotics and they produce opacities. Many times you know that the patient is a lymphoma patient and you may got mediastinal lymph nodes. Atypical pneumonia, and this may be due to fungus, TB, or alveolar sarcoid. Then these types of pneumonias do not respond to antibiotics. And then at that time, you consider it atypical pneumonia. The fungal pneumonia is seen usually in cancer patients, TB, as I have mentioned, and alveolar sarcoid. And in many of these cases, you go to biopsy. Then the nodular pattern. Nodular pattern. Random distribution. Is that random distribution? Okay. Random distribution according to the size. If less than 3 millimeter, consider TB. If less than 3 millimeter or more, consider metastasis. Okay. Centrilobular distribution. You remember the hypersensitivity pneumonitis, bronchoalveolar carcinoma, and pulmonary infection. Perilymphatic distribution, sarcoid, the causes, and lymphangitis carcinomatosis. The cystic pattern. Langerhans cell histiocytosis, and the history of smoking is essential. Then thick wall cysts, spare the lung bases, some of the nodules, and the cysts are in the range of 1 centimeter in diameter. Langerhans cell the lymphangioliomyomatosis, the young female in the productive age. Then thin wall cysts affect the whole lung, especially the costophrenic angle. Tuberous sclerosis is similar cysts to the lymphangioliomyomatosis. The patient had mental retardation, skin tumors, and angiomyolomas in the kidneys or in the liver. Cystic bronchitis, the tram track sign, signet ring sign, and so on. Then lymphocytic interstitial pneumonia, the patient with autoimmune disease, especially sugar, ground glass opacities, thin wall cysts, and sometimes mediastinal lymphadenopathy. Thank you, Ben.